Society Cardiology Cloud Forum of Cardiovascular Disease series. And this series, we have a lineup of excellent speakers to share with us very relevant topics on hunting precision targets in atrial fibrillation therapy. Who, when, and how. We've got a series of speakers representing the different countries from Asia Pacific. For this series of sessions, we're really going to discuss that the atrial fibrillation has the progress and on the knowledge of management of atrial fibrillation has made significant progress in the last 5 to 10 years now, and especially with the introduction of wearable devices, cardiac implantable electronic devices, even machine learning, artificial intelligence has also given us opportunity to not just clarify AF burden, but also the incidence and unprecedented risk for subclinical AF. Now, we know that the restoration of sinus rhythm and maintenance of sinus rhythm for patients with atrial fibrillation is also important, and we will also discuss on the role of antiarrhythmic drug therapy, ablation technologies, and also we discuss about left atrial appendage occluders, looking the role of prevention of strokes in this high-risk cohort of patients who cannot tolerate oral anticoagulation, and we'll discuss the pitfalls of various therapies for both paroxysmal and persistent atrial fibrillation. A bit of introducing myself. I'm Colin. I'm from Singapore, and I'm working in Changi General Hospital, which is the eastern end of the country near the airport. And I also visit in the National Heart Centre, Singapore. And I'm very honored to have a co-chairman, Dr. Kuan-Cheng Chang from Taiwan, Taichung. He's the Vice Superintendent of the Department of Internal Medicine, Director, Department of Medicine, China Medical University Hospital, Professor of Medicine, China Medical University. A bit of a disclaimer and house rules. The content of this webinar is copyrighted by the Asia Pacific Society of Cardiology and should not be distributed without the prior permission of APSC. The views and opinions expressed here are those of the faculty members, and they do not necessarily represent those of the APSC. Now, the good news is that the live streaming content of this webinar will also be made available via the APSC Cloud, Facebook, and YouTube page. So with this, I'd like to introduce our first speaker from Vietnam, and he's Dr. Hoang Tien, Associate Professor, Vice President of Cardiovascular Center of Hue University Medicine and Pharmacy Hospital. He's also the Vice Head of the Cardiology Department of Hue University, Vietnam. He will be discussing on the stratification of subclinical atrial fibrillation by AF burden in wearable devices or cardiac implantable electronic monitoring, targets of stroke prevention by oral anticoagulation. Dr. Hoang, please.
Yes, so good afternoon, the chairman. Good afternoon, the audience. So today's I would like to present the topic, the stratification of subclinical atrial fibrillation by atrial fibrillation burden in wearable device or CF monitoring is target of stroke prevention by OAC. As you know that the use of a wearable device and cardiac implanted electronic device for detecting atrial high rate episodes and their association with stroke risk and the use of anticoagulation for stroke prevention in patients with atrial high rate episodes have been subject for extensive research. And you know that the atrial high rate episodes, as known as subclinical atrial fibrillation, detected by the device is associated with increased risk of stroke at many studies. And we raised the question that how the importance of monitoring for detecting the subclinical atrial fibrillation, also at the use of oral anticoagulation for reducing risk of stroke in patients with the device detecting atrial fibrillation. So I'm going to talk about the epidemiology of atrial high rate episodes and subclinical atrial fibrillation. So the incident of the atrial high rate episodes and subclinical AF in patients with a pacemaker and implanted device is about around 30 to 70%, but it may be lower in the range population. And about the very short episode is below 10 to 20 seconds per day are considered clinical irrelevance. And they are not significantly associated with the longer episodes for increased risk of stroke or systemic embolism. However, the longer episodes of atrial subclinical AF, a minimum of 5 to 6 minutes, are associated with an increased risk of clinical atrial fibrillation, ischemic stroke, major adverse cardiovascular event, and cardiovascular death. So the absolute risk of stroke associated with atrial high-risk episodes, subclinical AF, may be lower than with the clinical AF. And the temporal association from the acute stroke suggests that the atrial high-rate episodes and subclinical AF might present a marker than a risk factor of stroke. And so I would like to introduce the study, talk about the clinical device detecting atrial fibrillation and stroke risk. This study is a systemic reviews and meta-analysis. So the definition and cutoff of detecting a subclinical atrial fibrillation with the three device by the Medtronic, by the HCM, by the Biotronic, and its vendor has the criteria for atrial high-risk episodes, the criteria for the cutoff to recognize the clinical AF, and also the criteria for duration of the subclinical AF, except for the stroke risk. So we can see that three is the main vendor, but the criteria is different from each other. And with the study, they will conclude, have the result that there's the association between the subclinical and clinical atrial fibrillation. This means that when in clinical, we detect the subclinical AF, and it can lead to the clinical atrial fibrillation in the real life. So the result is very significant with the p-value is very low. And the next result that this study can find out the association between the subclinical atrial fibrillation and the stroke risk. And also the p-value is very significant. It means that there's a strong relationship between the subclinical atrial fibrillation and stroke. And with this study, they also conclude that the atrial high-risk episodes detect in 30.9% in the patient annually. And the patient with atrial high-risk episodes have the 5.7-fold more like to have a clinical atrial fibrillation. And also very important finding in this study that they said that if the patient with the CHART score is 2 and above is very well above a step, the current threshold for anticoagulation to prevent the shock. I think it's very important finding of this study. And the next, I would like to introduce about the ESC, European Society of Cardiology guidelines in 2020 for diagnosis and management of atrial fibrillation. And with this guideline, we can see that there is very clearly defined the definition of the AF and subclinical AF, also as the atrial high-risk episodes. For example, the atrial high-risk episodes is defined by the event fulfilled program or specific criteria that detect by the cardiac implant electronic device with the atrial lead allow automatic continuous monitoring of atrial rhythm and tracing storage. So the CF recording atrial high-risk episodes need to be visually inspected because some atrial high-risk episodes may be electrical artifact and phase positive. And the definition of subclinical atrial fibrillation includes the atrial high-risk episodes confirm that AF and atrial flutter, atrial tachycardia, atrial fibrillation episodes detected by the inceptible cardiac monitoring or variable monitoring and confirmed by the visually revealed intracardiac electrogram or EKG record rhythm. And so the device program criteria for the atrial high-risk episodes is above 175 beats per minute. And the criteria for atrial high-risk episode duration is above the 5 minutes. So this is a very important definition for the further investigation. And you know that the atrial fibrillation as also the subclinical atrial fibrillation has the same mechanism of the causing the stroke, causing the connective impairment, dyspnea, depression, hospitalization, and mortality due to the pathophysiology mechanism and structural remodeling. Also the rapid ventricular rate, irregular heart rate, and loss of atrial systole. And there are similar the mechanism between the subclinical AF and AF. And you know that we have a lot of the instrument for the atrial fibrillation screening. For example, the method of pulse taking, the automatic blood pressure monitor, the single lead EKG, the smartphone app, and also the watch. And the above instrument have the highest sensitivity and also high specificity in diagnose the AF, also at the subclinical AF. And you can see a lot of the instrument, for example, the watch, the implantable cardiac monitor, and the pad for the 1 to 2 week continuous monitor, the Holter and monitor, and also some handheld EKG. And about the diagnosis of atrial high-risk episode and subclinical AF, the continuous the cardiac implanted electric device with atrial lead can monitoring atrial rhythm and storage tracing. In this figure, we see that when the patient has no symptom, no previous diagnosed clinical AF, and we use the CS record device, and with the EKG, we can confirm the AF. But when the EKGs, the normal EKG cannot find it, but the CX can find out the EKG, so we can classify yes as the subclinical AF. And we also know that we still lack of the information, lack of the study for the conclude about the evidence how we can treat with subclinical AF. And in Vietnam, we also have the guidelines about the atrial fibrillation of the Vietnamese Heart Association. It's also the full version and also the abstract version. And it also talk about the subclinical AF, also as the atrial high-risk episode. So about the clinical implication of atrial high-risk episodes and subclinical atrial fibrillation. You know that clinical AF will reportedly develop in in 5 to 6 patients, and within the 2.5 years after diagnosis of atrial high-risk episodes and subclinical AF. And even though the more high-quality evidence need to inform to management of the patient, the more intense follow-ups and monitor to detect clinical AF early is prudent. And notably, the atrial high-risk episodes and subclinical AF burden is not static, but may change on daily basis. The higher risk subsequent progress to longer episodes. And whereas available evidence is insufficient to justify the routine oral anticoagulation used in this patient, the modified stroke risk factor should be identified and managed in each patient. And we can also see the progression of atrial high risk episode segment and stroke rate according to the atrial high risk episodes daily burden and Sharp score. Here's the 6-month Eastern transitions to the higher atrial high risk burden. And you see that in the patient with the atrial high risk episodes from 5 to 1 hour have the 33.5% transition to 1 hour, and when the patient has the 12 to the 23 hour of the length of the atrial high risk episodes will transition to the 6-month progression to above 23 hours is the very high rate with 63.1%. And also the stroke rate in the atrial high risk episodes burden and Sharp, we see that the intervention with the Sharp score larger, we have the higher of the incident of atrial fibrillation. And the recommendation for the management of the patient of atrial high risk episodes in the APSC 2020, they said that we should complete cardiovascular evaluation of EKG, recording clinical risk factor, comorbidity evaluation, and thromboembolism assessed for example Sharp score, and we continue patient follow-up and monitoring, prefer with the support remote monitoring for detect progression of clinical AF and monitor the atrial high risk episodes burden, especially transition to 24 hours to detect the change and detect the change underlying clinical conditions. And about the management of atrial high risk episodes and subclinical atrial fibrillation. So the use of oral anticoagulation may be considered in the patient with a longer duration of the atrial high risk episodes above 24 hours and estimates a high individual risk of stroke according to the anticipated clinical benefits and informed patient preferences. And in recently trial, the oral anticoagulation were initiated in 76.4% and 56.3% of patients with above clinical stroke risk factor, injectable cardiac monitoring, detect physio-confirmed AF for about 6 minutes, but the follow-up lead-in rates were not reported. And in last retrospective cohort, using the remote monitoring data about AF burden, there's a large practice variation in the oral anticoagulation condition. So across the increasing AF burden SATA from the above 6 minutes to 24 hours, the risk of stroke in unchecked patient is increased numerically, and the strongest associated with the oral anticoagulation with reduced stroke and observed amount of patient with the detect AF episodes for 24 hours above. And so the guideline also proposed the management for the patient with the atrial high risk episodes and subclinical AF. So the patient with the high risk due to the Sharp score is about 2 mark in the male and 3 mark in the female, and have the longer of atrial high risk episode, for example, about 1 hour to 24 hours, about 24 hours, we should consider to use oral anticoagulation in the selected patient with high and very high risk of stroke. For example, the patients with age above 75 years old or Chokesuwattanaskul below the 3 mark, we can should consider to use oral anticoagulation. So we can mention that higher Sharp and longer atrial high risk episodes have the suitable to use oral anticoagulation. And so I will introduce the newest trial that's finished in the November in 2023 about the non-vitamin case antagonist oral anticoagulation in patients with atrial fibrillation episodes. It's from the study NOACS and AFNet. This study, this trial is also stopped due to the safety and futility. And two main outcome is the efficiency outcome composites of cardiovascular, death, stroke, and systemic embolism for edoxaban is not different to the placebo. But the primary safety outcome composites on cause mortalities, edoxaban and placebo have the different of the significance. So this trial is concluded that edoxaban associated with the increase the primary safety outcome and driven predominantly by more frequently measured bleeding event. And the next with the trial, we also have the paper about the anticoagulation with the edoxaban in the patient with the atrial fibrillation episode. It's also very detailed about the clinical trial, but you know that the result is not so positive that among the patient with the atrial fibrillation episodes without atrial fibrillation, the incidence of composite cardiovascular death, stroke, and systemic embolism with edoxaban has not significant different from the placebo. And the treatment of edoxaban lead to higher incidence of composite death or measured bleeding. So this study have five notes different in the edoxaban for versus the placebo in the patient with the atrial fibrillation episodes. And the next trial is the APSC for the reduction thromboembolism patient with device detect subclinical atrial fibrillation is the trial from the Australia. And this finding have two major outcomes. The first outcome is the stroke and systemic embolism. And after this trial, they conclude that the rate, the difference in the patient use APSC is very significant compared to placebo group. And so, and with the primary safety outcome, the measured bleeding is also different from the placebo. So they can conclude in this trial with the APSC will reduce the stroke or systemic embolism. And so we need to balance the risk of the measured bleeding compared to the aspirin. And also the study, the paper about the APSC for stroke prevention in subclinical atrial fibrillation. And they conclude that among the patients with subclinical atrial fibrillation, APSC results in a lower risk of stroke or systemic embolism than aspirin, but the high risk of measured bleeding. It's a very important conclusion about the APSC. So APSC is have a more positive results compared to the edoxaban. So with the study and with the guidelines, I can conclude about the topic that the evidence suggests that the atrial fibrillation episodes detected by the wearable and cardiac implantable electric device is associated with the increased risk of stroke. And the stroke with the subclinical atrial fibrillation is at low compared to clinical AS and could potentially represent a small burden. And the use of oral anticoagulation therapies may be beneficial and reduce risk, particularly in patients with a longer duration of atrial fibrillation episodes and high individual risk of stroke. APSC results a low risk of stroke or systemic embolism than aspirin, but a higher risk for measured bleeding due to the atrial trial 2023, and Endosabang was associated with the increase in primary safety outcome with the trial NOAC APSC trial 2023. So thank you very much for your attention.
Thank you very much, Dr. Huang, for your sharing. Is there anybody like to have any questions during the Q&A sessions? Or Dr. Chang, do you have any questions you'd like to ask?
Oh, very good. No, I have no question. Thank you.
So, Dr. Huang, it's great that you get to share with us the two most recent trials with subclinical atrial fibrillation and anticoagulation, Artesia versus NOAA AF-NET6, using two different direct oral anticoagulants, but seemingly different outcomes. I mean, apixaban reduced embolic events at the price of bleeding. Edoxaban did not seem to reduce embolic events and still pay for the price of bleeding. What do you think is the reason for the difference? Do you think it's just the drug difference, or is it the design of the trial or the criteria for AHRE that's different?
Yes, thank you very much for your interesting question. So I think that the two news result from two trial. The first is Atrial is very good for the apixaban that can reduce the risk of stroke and systemic embolism. But in the trial NOAA AF-NET6, the edoxaban not reduce the risk of stroke. I think maybe you know that the subclinical AF is mean that the atrial fibrillation that's detected by the device by the CF cardiac implant electronic device is similar to the AF, but the atrial high risk episodes I think is because the criteria for diagnosis of atrial high risk episodes is different from the trial, and so we should use the criteria of the European Society of Cardiology 2020 for the follow-up and evaluation the patient, and it's very suitable if we devise two types. One is the subclinical AF detected by the device, and another is atrial high risk episodes detected by device, because I think the two types of this disease is different from the morphologies of the AF in the EKGs, because the atrial high risk episodes is the high risk of the atrial rhythm. I think that's in the near future they will stop. It means they will have the more detailed and more specific group between the two groups of patients, and also we should focus on the patient with the highest episode of atrial high risk episodes. For example, have the burden more than 24 hours, for example, and we should find the different and the efficiencies of edoxaban, also apixaban in that patient.
Thank you very much. So with this, we'll go to the second speaker. The second speaker is Dr. Takafumi Oka from Japan. He's the Assistant Professor, Department of Cardiovascular Medicine, Osaka University, and also the EP Chief Doctor in Osaka University Hospital. His topic today will be choosing antiarrhythmic drugs first or catheter ablation as first strategy for recent onset AF management, and does AF burden matter? Thank you very much, Dr. Oka.
Oh, good afternoon, everybody. I'm Takafumi from Japan, Osaka University. I will share my presentation now. Can you see my presentation?
Yes, it's good. Thank you.
Okay. Thank you, Chairperson. I'd like to thank the organizers to give me a chance to make presentation here. Today, I will talk about the association between AF burden and treatment strategy. COA disclosure. This is the agenda of today's presentation. Let's start with section 1, great progress in catheter ablation for AF. Here, let's review the two famous RCTs 20 years ago. Both the AFFIRM and the RACE studies compared the effectiveness of pharmacological rhythm control and rate control for AF. We expected that maintenance of sinus rhythm by rhythm control would result in a better prognosis than rate control. However, there was no superiority in rhythm control. The side effect of anti-arrhythmic drugs, AAD, might impact on this result. The negative inotropic effect could exacerbate heart failure, and the pro-arrhythmic effect could cause bradyarrhythmia or fetal tachyarrhythmia, canceling out the benefit of rhythm control. This is the limit of drug treatment. During the same period when AFFIRM and RACE were being conducted, pulmonary vein isolation by catheter ablation was invented. By electrically isolating the arrhythmic trigger in the PV with radio frequency ablation, maintenance of sinus rhythm could be achieved. The era of non-pharmacological therapy for AF has arrived. In the MANTRA path, RAFT-1 and RAFT-2 trials, the effect of RFCA on PAF was compared with that of AAD. The result of that meta-analysis showed that RFCA was superior to AAD in terms of AF suppression. Ablation has been recognized as the first-line therapy for PAF. The problem with RFCA was pulmonary vein reconnection in the chronic phase, and there were limitations in analyzing complex arrhythmia circuits of atrial tachyarrhythmia. However, with the evolution of contact force-guided RFCA and high-resolution 3D mapping systems, RFCA has made significant progress compared to before, and its efficacy and safety have improved. As RFCA had made progress, the introduction of cryoballoon ablation, CBA, as a new ablation tool had a great impact on AF ablation. The Fire and Ice study proved that CBA had the same efficacy and safety as RFCA. CBA allows even beginners to perform durable PVI simply and reliably in a short time, and it has become widely popular. Very recently, pulsed field ablation could be a game changer. In the Advent study of 2023, the AF suppression effect of PFA and thermal ablation, such as RFCA and CBA, was compared and proven to be equivalent. PFA is likely to be able to perform durable ablation in a short time, and PFA also may reduce collateral damage, which is a weakness of thermal ablation. Until now, the primary endpoint of RCTs has mainly been the AF recurrence, but ATTACK trial and the CASTLE AF trial investigating the impact of ablation on CHF use a hard endpoint as a primary endpoint, such as all-cause death, stroke, major bleeding, cardiac arrest. The CABANA trial, which examined the impact on prognosis between ablation and AAD for more than 2,000 people with symptomatic AF, is the largest scale trial. In the ITT analysis, there was no significant difference due to the high number of crossover from the AAD to ablation group. But the per-protocol analysis showed the prognostic improvement in ablation group. The cast ablation may improve prognosis of AF patients. To summarize what we have learned from our CTs, first, ablation reduces AF burden more than AAD. Second, ablation may improve prognosis of AF patients. While ablation seems beneficial, the question of whether we should recommend ablation to all AF patients is not that simple. The background of AF patients is miscellaneous. We recommend ablation in clinical practice considering these various factors. Today, I will focus on AF burden among them. Second section, does AF burden matter in AF treatment strategy? AF burden is defined as the amount of AF that an individual has. Classically, it is the AF type. Paroxysmal, persistent, and long-standing persistent are easy to understand indicators, but they are not suitable for stratifying patients with a low AF burden. Recently, by using cardiac implantable electric devices, CEDs, and long-term Holter monitors, the proportion of AF duration to monitoring period expressed as a percentage has been used as AF burden. This is quantitative and reliable in patients with low AF burden. AF burden correlates with the AF progression. Generally, persistent AF is more advanced than paroxysmal AF. After treatment such as AAD, ablation, and cardioversion, persistent AF has more recurrences than PAF. This is a sub-analysis of Kavanagh study about recurrence by AF type, PAF, and persistent AF. Blue represents AAD and red represents ablation. But both before and after intervention, the AF burden is clearly less in PAF and larger in persistent AF. In patient selection for RCTs, AF burden is an important item. Looking back at the past RCTs, the efficacy and safety of new technologies are conducted on simple PAF cases. The beyond PBI studies are conducted on persistent AF cases. And the effectiveness of ablation for CHF is also conducted on persistent AF cases, which are greatly affected by AF burden. Recently, there has been a growing interest in early rhythm control, ERC, for AF. This is the prognosis of gastric cancer. In the case of cancer with a poor prognosis, early treatment can significantly improve the prognosis. What about AF? It's not as poor a prognosis as cancer, but it can cause mortality, heart failure, and stroke. The East AF Net 4 in 2020 compared early rhythm control, ERC, and rate control. Patients diagnosed with AF within 1 year were enrolled, and ERC was performed with either AAD or ablation, while usual control was primary rate control. The prognosis was better with ERC, although ERC group had a low ablation rate of 20%. In 2021, an RCT comparing the effectiveness of CBA and AAD as a first treatment for symptomatic and treated PAF was published at the same time. The primary endpoint was AF recurrence. Both showed good results with ablation. CBA works better than AAD for early PAF. Notably, in early AF trial, recurrence was observed by implantable cardiac monitor. the true recurrence rate was unveiled. The symptomatic recurrence rate was 11% after the first ablation, but when combined with asymptomatic AF, it was 43%, and the recurrence rate was 34% after multiple sessions. The mean AF burden did not differ. Thus, asymptomatic recurrence often occurs. In the long-term follow-up of early AF, it was found that performing CBA during PAF could suppress the transition to persistent AF. Similar results by RFCA have been reported from Germany. The ATTEST study showed that if RFCA is performed during PAF, it can prevent the transition to persistent AF compared to AAD. The suppression of disease progression was the merit of ablation for PAF at an early stage. Of course, some patients consult with PAF and others consult with persistent AF, but it seems beneficial to perform early rhythm control. I wonder, the earlier the better. If we pursue ERC, an intervention at the point of very low AF burden, such as first diagnosed AF and subclinical AF SCAF. Let's review the impact of AF burden on prognosis. First, classically, when dividing patients by type of AF, such as paroxysmal, persistent, and permanent, the longer the AF duration was, the more stroke occurred. There was a correlation between AF burden and prognosis. In the sub-analysis of East AF Net 4, the event rate was examined on the basis of the type of AF. In the group with APAF, ERC significantly improved the prognosis, and a similar trend was observed in persistent AF. In this RCT, ablation was less at 20%. If more ablation were performed, the effectiveness of ERC might increase. Among the patients in East AF Net 4, 1,000 first episode AF patients were enrolled within 7 days of their first visit. There was almost no difference in the effect of the intervention. It can be said that it is not too late to start treatment after observing the course of a PAF for a while, rather than intervening immediately when the first episode AF is found. This paper examines the progression of the first episode of AF. Among the first episode AF, half experienced no recurrence in 5 years. Less than 20% showed transition to persistent AF. Patients with no long AF showed AF progression, which suggests that AF high-risk groups with comorbid disease should be watched carefully. I'll also touch on SCAF, subclinical AF. Recently, thanks to seed and wearable devices, intervention in SCAF has become a topic of discussion. SCAF is defined as asymptomatic AF that is only detected by seed and wearable devices and is not captured by ECG. A lot of studies investigated the association between SCAF and CV events. Generally, high SCAF burden is associated with embolic stroke. Furthermore, SCAF often progressed to symptomatic AF-AT and was also related to the onset of CHL. The study examining the efficacy and safety of drugs for SCAF was published in 2023. Apixaban demonstrated its effectiveness while edoxaban did not. Bleeding events increased in both studies. In the future, analysis will progress on patient groups where the benefit of drugs outweighs the risks. when it comes to catheter ablation, which is more invasive, I think more stratification is necessary. In summary of early rhythm control for patients with a low AF burden was associated with cardiovascular events risk. However, risk and benefit of ERC should be considered in each patient. In section 3, I will discuss which patient benefit from early rhythm control strategy. In the sub-analysis of East AF Net 4 by the severity of symptom, the effect of ERC was more evident in cases with severe symptoms. We should recommend ERC to symptomatic patients in order to improve their quality of life. This study showed a tendency for improved prognosis with ERC even in asymptomatic cases. In the Chokesuwattanaskul specific analysis of East AF Net 4, ERC improved the prognosis of the patients with a high Chokesuwattanaskul score. In those with low Chokesuwattanaskul score, there was no difference. Since Chokesuwattanaskul correlates with prognosis risk, ERC is recommended for patients with a high Chokesuwattanaskul score. This is a result of Code AF from South Korea, investigating the effect of ablation on asymptomatic AF. Symptom was quantified by AF EQT score. Even in asymptomatic patients, if the CHAS score was high, there was an effect of improving prognosis, which is consistent with the sub-analysis of East AF Net. In the sub-analysis of East AF Net 4 based on the presence of heart failure, ERC was effective in case with heart failure. Analysis was added in HFrEF at heart failure mid-range EF and HFpEF cohorts, but no statistic significance was observed, possibly due to underpower. Because AF is a factor that exacerbates heart failure, early intervention is reasonable. In the sub-analysis of Cabana study by symptomatic CHF, ablation improved prognosis. Among 778 patients with CHF, median LVEF was 55%, and less than 10% of patients were HFrEF. Since AADs have side effects which worsen the prognosis of patients with a heart failure, ablation may be optimal as ERC for CHF. I have presented about AF burden and ERC. The methods to detect AF have increased compared to before, and it is anticipated that situations requiring considering of ERC will increase in daily medical practice. This is my take-home message. First, AF burden matters when we discuss the strategy for all AF patients. Second, AF burden, symptom, Chokesuwattanaskul scores, and CHF should be considered in ERC. Third, we should carefully recommend ERC to patients with low AF burden. ERC must be a tailor-made therapy. Thank you for your attention.
Thank you very much, Dr. Oka.
Thank you.
I like it that you bring together the different kinds of low AF burden. Just wanted to ask, so you shared about who are the patients, the benefits of early rhythm control. So I was wondering, who are the patients you would not offer early rhythm control if they have a newly diagnosed AFib or first onset of AFib?
Oh, thank you. That's very good, very important point. I don't agree with the notion that ERC should be recommended to all patients. I don't want to recommend ERC to patients with low risk, asymptomatic, low CHAS score, no symptom of CHF. I want to recommend ERC to the high-risk patients.
Okay, thank you very much. Any questions from my co-chair or anybody else?
Okay, just a short question. Very good presentation. You mentioned about you will use ERC in high risk patient.
Yeah.
So if patient with a high Chokesuwattanaskul score like more than 4, so the and he or she has a subclinical or atrial high rate episode. So what about the duration? You will consider how long the duration you will initiate ERC in this high risk patient. Thank you.
Oh, thank you. Oh, I think the AF duration at more than 24 hours is associated with stroke risk in the previous report. So I recommend the more than 1 day. More than 1 day lasting AF is harmful.
Okay, thank you.
Thank you very much. So I think we can introduce our third speaker, who's from Thailand, Dr. Ronpichai. He's the attending physician cardiovascular medicine from King Chulalongkorn Memorial Hospital, Bangkok, Thailand. And today he's going to share with us on radiofrequency catheter ablation, cryoablation, or pulse field ablation for interventional pulmonary vein isolation in atrial fibrillation, efficacy comparison, and targets of choice. I think this is something that many of us are grappling with it now. So thank you very much, Dr. Ronpichai.
Good afternoon, everybody, and thank you, Mr. Chairman, to kindly introduce me and the topic that we're going to discuss this afternoon. So let me share my slide. Can you see my screen?
Yes, we can. Thank you.
Okay, let me start real quick. Okay, so to the topic, we're gonna touch up the options available for the catheter ablation for atrial fibrillation. As the prior speakers discussed about the pros and cons between antiarrhythmic agent and ablation therapies, I think now we are going into the era of very many options to do the pulmonary vein isolations. So the next 20 minutes, we're gonna touch up to about pros and cons between those different options. There's no doubt that the PV isolation is a cornerstone treatment of paroxysmal atrial fibrillation according to the ESC guideline and ACC guideline that just released in the past month. So basically, every patient comes in with AFib for ablation required to have the PVI as a minimum therapy. But the other ablation strategies, including the posterior wall isolation, cafe ablations, it's uncertain and it was put as the recommended guideline as a 2B class of indications. So we're gonna update about the PVI aspect first. Efficacy of the PVIs, as we know, it's all about the durability of the PVI. As long as you can maintain the PVI, it is associated with the lower risk of AFib recurrence after ablations. As we know that there still so far has not have any evidence to support other ablation strategies, including triggers ablations, cafe ablations, and additional tests post-PVI did not confer any higher benefits than without testing after PV isolations. And the complications rate is even getting lower and lower is ignorable because cardiac tamponade, esophageal injury, specifically atrioesophageal fistula, or subsequent proarrhythmic from ablation, which is atypical atrial flutter or PV stenosis, might have to be taken into the consideration when we pick up the ablation strategies for the patients. So it seems that we are going to the era that less is more still hold the truth when we are dealing with the first catheter ablation for the patients. We're going to talk about the durability of the PVIs. What I mean by the durability of the PVI is the aim of the ablation catheter is just try to isolate all the PVs. And when we can isolate all the PVs, we can eliminate atrial fibrillations. However, about 30% of the patient in most of the cohorts has AFib recurrence, which is associated with what we call PV reconnection. So this is the picture that demonstrates the concept of the PV isolation from the patients who come in for the RF ablation. The red dot line is the area or the line that we apply the RF along the line that connects between the PV and the LA antrum. So the concept of the PV isolation is just try to prevent the electrical impulse from the pulmonary veins going to trigger the AFib into the LA. Once we can isolate the veins, all four veins from the PVs, not allowing the electrical impulse from the PVs into the LA, then we believe that we can stop AFib and can maintain the status flipping for the patients. However, the success rate is not 100% for the RF, including cryoballoon, as we might include both strategy as a thermal ablations, because a lot of patients experience what we call the PV reconnection. PV reconnection can be occur during the acute episodes or the long-term episodes. A lot of studies try to explain and try to see and observe the correlation between the acute and the long-term PV reconnections. So this graph, you can see that we will not be surprised to see the PV reconnections, because in the RF, you're going to apply the single lesions as a contagious patterns. So there is a possibility that the patient might have a gap, which allow the connection between the PVs into the LA. And the studies also prove that the common area of the reconnection, either acute and long-term, is the area that's hard to ablate, including the carina, which is the area that is the joint area between the top and the bottom veins. So a lot of operators try to invent the technologies that try to isolate the veins at the same time. As you might see, the cryoballoon ablation strategies on the right and on the left. I would like to show the comparison between the good occlusion, which means after injected contrast into the tip of the cryoballoon catheter, you will see the contrast back leak into the upper branch of the pulmonary veins. This means that you get a very effective occlusions. And as soon as you see this fluoroscopy, you can apply the temperature into the balloon, and the cold freezing will take about 180 to 240 seconds to freeze up and kill the tissues around the pulmonary veins. However, if you look on the right side of the screen, with the same maneuvering system that we inject the contrast, and you're gonna see the leak of the contrast out on the lateral part of the balloon. This means that you cannot get a good contact of the balloon on the PV ostoms. And if you apply the cold energy in this area, it's not gonna work to isolate the veins. That is the reason why a lot of effort try to invent the new technology and tool, including the instrument that try to isolate the veins in one shot, but it's still not gonna be 100% success rate for the cryoballoon. So trying to compare the two conventional approach for the catheter ablation for the PVIs, there are randomized studies that I'm gonna show you to test the effective of the cryoballoon and the RF. There is the 1-to-1 randomized study, randomize the patient into the RF and the cryoballoon, and the follow up the patients per protocol at 4 to 6 months by repeating mapping procedures, comparing between the cryoballoon and the RF. This is the RF on the left. We're gonna see the PV reconnected area. We can appreciate the difference between the RF and the cryoballoon in terms of the PV reconnection at 6 months. So the reconnection area in the RF group seems to be clustered around the carina area. However, in the cryo balloon group, the PV reconnection spot seems to be heterogeneity distributed along the PV ostiums. With the efficacy for the AFP3 or the durability of the PVI, it seems to be pretty similarities between the RF and the cryo balloon, because in 98 patients in this randomized studies, 81% versus 76% still have the PVIs from the cryo and RF respectively. So the efficacy of the cryo and RF seems to be pretty close to each other, but just different on the area of the PV reconnections. Here comes with the new technologies that will just want to fill the gap in terms of the safety endpoint. The technology is called the pulse field ablations using the specialized energy from electrical field that selectively damage the tissue of interest, which is the myocardium from the left atrium. So the pulse field ablation technology preserve and avoid the collateral damage to the adjacent structure, including esophagus and phrenic nerve. So in theory, this pulse field ablation has a basic advantage over the thermal injury in terms of the safety by avoiding collateral damage to the adjacent structure, namely esophagus and phrenic nerve. With the new technologies coming out in the past 5 or 6 years, a lot of studies try to explore the difficulties to master in the pulse field ablation. One of the studies that tried to look into the learning curve by the operators, it seems that the procedure time is pretty short, about 80 minutes to complete the PVIs. But we observe a significant increase in the fluoroscopic time in the pulse field ablation group, about 20 minutes. However, in these pulse field ablation procedures, they were all done by the operator who are experienced in the thermal ablation procedures. And the first pass isolation achieved about 98%, which is pretty impressive compared to those prior conventional ablations. So I'm going to focus on only 3 options available and which are the most popular nowadays worldwide for the PV isolation. They are pulse field ablation, cryo balloon ablation, and RF. We are not going to talk about the optional energy source or catheter type like a laser balloon in these lectures. This is the meta-analysis to compare the efficacies of the first pass PV isolation. It seems that every single modality of the ablation, PFA, cryo, and RF, confer a very good result for the PVIs ranging from 71% to 87%, which is not statistically significant from each other. But if you just look at the number roughly, you're going to see the pulse field ablation seem to have the highest durability of the PVI in this meta-analysis. When comparing with these 3 options, the cryo balloon and RF have a similar performance on the durability of the PVIs, and the PFA has the highest durability rate when follow up the patient at 12 months. However, with the statistical analysis, there's no significant difference between these 3 options. What about the safety when they claim that the first pulse field ablation came out and proved the concept to have the 0% of the esophageal injuries? In some studies in the past few years, because of the new technology, not just developed in the field of the pulse field ablation, we have a lot of technology and strategies to mitigate the effect of the esophageal injuries. So one of the studies that I just want to pinpoint to show that esophageal epithelium is about 0 in almost 300 patients. The complication rates from these 3 different options is very low, which is ignorable complication rate in cardiac tamponade on pulse field ablation group. And here comes with the most recent randomized studies trying to compare the pulse field ablation to conventional thermal ablation. And the conventional thermal ablation could be either cryoballoon ablation or RF, but based on the operator preference in particular centers. So this is a randomized single-blind non-inferiority trials comparing the cryoballoon for the PVIs in paroxysmal atrial fibrillation. We can see the very close Kaplan-Meier curve for the AF-free survival at 1 year between the group with the pulse field ablation and thermal ablation as about 70%. So in these studies of the very big randomized studies, we can conclude that the pulse field ablation was non-inferior to the conventional thermal ablation, either cryoballoon and RF. Here comes to the point that when we are discussed about these three available options, we need to look from different lenses before pick up each strategies for our patients. So let's start out with the efficacies. All of the randomized studies prove the similar efficacy between these three options by having the 70 to 75% AF-free survival rate at 1 year between these three options. So I think the efficacy of these three options is pretty close to each other. And about a complication rate, nowadays we are going to what we call the near zero esophageal injury era, because atrial esophageal fistula is the most devastating complication for the RF ablation in the patient with AF. And from the pulse field ablation large cohort study looking into 1,600 patients, they found a zero incidence of the esophageal injury in the pulse field ablation. Also, in the era of in the past few years with the concept of the high power short durations, we place the catheter in a very short amount of time on each particular point in combination with the esophageal monitoring. The incidence of the esophageal injury in the thermal ablation groups go even lower to lower until it's approaching the zero. So I think with the patients in general population, we can say that it's a very close incidence of esophageal injury compared to these three available options. And what about the operation time? The major area that I just want to pinpoint is about a fluoroscopic time, because we can do the zero fluoroscopic ablation in the RF by the assistance from the electroanatomical mapping under the 3D guided approach. So many PVIs have undergone without a fluoroscopic assistance. Still, we need to use some fluoroscopy during the cryoballoon ablation by confirming the position of the balloon that it just abut on the PVI stems. We have to inject the contrast and look under the fluoroscopy to confirm the position of the balloon before apply the cold energy. But it just takes about 2 or 3 minutes for the whole procedures. The last thing, but it's gonna be even shorter over the period of time that I strongly believe, because from the recent study, it takes about 15 to 17 minutes for the pulse field ablations. So compared to the these points of view about the operation times, it seems to be pretty shorter for the whole procedural time for the pulse field ablation, but with a significant higher fluoroscopy exposure or radiation exposure to the operators with a pulse field ablation. And what about the learning curve? I think this is the area that we cannot directly compare between these three available options, because most of the centers that conduct a study about a pulse field ablation were operated by very experienced operators that are very good at catheter skill in the RF and the cryoballoon. But it seems that it takes a very short learning curve to master the pulse field ablation. What about the evidence? I think a lot of evidence prove the efficacy, safety for the thermal ablations, and a growing body of evidence will prove the concept of the pulse field ablation for the persistent AF in the future. here it comes to my personal opinion about how we select the patients suitable for each particular ablation strategies. So I think if the patient comes in with a PVI, there's no much difference between these three available options. However, with the patients who are very likely to have atypical atrial flutters, and we try to avoid the extensive ablation on that patient, RF might be preferable options to me. For the correction, it's going to be very quick, fast in the patient with pretty straightforward anatomical for the PV. And the pulse field ablation is very recommended in the patient's profile that is prone to the atrioesophageal fistula, like a very small ladies or patients. And I think they are developing the catheter to perform like the RF energy. This is the reason why I mentioned about the preference when I see the patient with atypical atrial flutters and select the RF, because this is an example of the patient who comes in for the atypical atrial flutter and persistent AF ablation after 2 prior ablations of AFib. And the presenting rhythm was atrial flutters. And we mapped the atrial flutters, its micro reentry on the lower posterior wall. And as soon as the first burn comes in, we terminate the atrial flutters. And no more flutter could be induced in that procedures of index. And we call it a day because it's success. And the patient has been AF and flutter free for 1.5 years. So this is the point that I think is very important to focus about trying to avoid extensive ablation in the patient with an extensive scar, because we hit about the atrial cardiomyopathy and atrial stenosis. The topic that I cannot cover in this lecture is about new technologies trying to be invented to fill the gap in terms of the safety and efficacy, including the high intensity focused ultrasound and the highlight laser ablation system. Thank you very much.
Thank you very much, Dr. Ronpichai. Very nice summary of the 3 prevailing technologies. Dr. Chang, any questions you'd like to ask?
No.
So, how have you personally started using PFA in Thailand now?
No, not yet. But we use a lot of RF. Mainly, I can call RF-based ablation. But my experience with cryo balloon and good friends of mine from Singapore, I know that Singapore, they use also like ECPC stuff, including Hong Kong. Just went back from the APSC and have a chance to discuss with friends of mine. They said, if you are very master in the cryo balloon, the pulse field ablation is going to be pretty identical to the cryo balloon. But in Thailand, we have about the reimbursement issues and any new technologies. I wouldn't expect to have a chance to do the pulse field ablation by my own in the next 1 or 2 years.
Yeah, I think I agree with you. This is really sensitive to individual countries' healthcare system and the reimbursement. And this is definitely a technology that is not cheap.
Right.
Okay, Chairman, just a short question for the speaker. You mentioned about you prefer using PFA in some high-risk patients. So what are the high-risk patients you mentioned?
Yeah, I think all of us as the ablationists hit esophageal fistula because AFib ablation and every single patient who comes in with a clinical profile that put them at the very high risk of the AE fistula, like a very small lady, old ladies who is very frail, which is supposed to have very small amount of the fat between esophagus and the left atrium. And you can see the evidence when we do the RF with the esophageal probe in this kind of the patients. As soon as you turn the RF on, the Prof will beeping up, alerting about the shooting up the temperatures. So I think select the patients with this clinical profile for a PFA gonna be a good options. And I know that the vendors specific, they're trying to develop the 2-in-1 catheters that they can use alternating between the RF and pulse field at the same time. But I think it's still under the experiment. Hopefully it will come out in the next few years.
Okay, thank you. Okay, so next move to the fourth presentation by Dr. Huang from Taiwan. Dr. Huang is a clinical lecturer in medical college at National Taiwan University. He also is a attending physician in cardiology of National Taiwan University Yunlin branch. The title of his presentation today is Artificial Intelligence Enables Sinus ECG in Prediction of Incident Atrial Fibrillation, Current, and the Near Future. Dr. Huang, please.
Thank you for Professor Zhang's well kindness introductions. And let me share my screen first. Okay, so can everyone see my presentation slide?
No problem.
Okay, thank you. So I'm Huang from National Taiwan University Yunlin branch in the central Taiwan, also near Taichung. And today my topic is the artificial intelligence AI-enabled sinus ECG in the prediction of the incident atrial fibrillations. As we know, artificial intelligence is play very important roles in the medicine in other areas, and also recently in the cardiology field, especially in the EP field. I think the artificial intelligence will play a very, very important roles, but we also in the crossroads. We need to know how AI will guide us or how AI can help us to do the personalized medicine. It's very interesting and also very important targets. So before I start my today's presentations, as we know, from the 2020 APSC guidelines, the clinical atrial fibrillations should be documented by the service ECG, either by the single lead ECG, document atrial fibrillations reason more than 30 seconds, or an entire complete EKGs. And how about this year's ACC/AHA guidelines? There is a very special or specific target in the appendix of these guidelines. It indicates artificial intelligence may be in the atrial fibrillation management, maybe have its rules. The artificial intelligence can potentially use to better tailor therapy to the individual patients, like the personalized medicine. But this is focused on the atrial fibrillation management. But our today's topic is, can sinus ECG predict the future atrial fibrillation events, or can predict the future atrial fibrillation disease? So this is today's my outlines. I will first brief introduction, current knowledge about the artificial intelligence and maybe the rationale of the using AI to predict the future atrial fibrillations. Then I select the 3 representative studies, all published in the well-known and very excellent cardiology journals. These studies, and I will briefly introduce this study to all the audience. And later I will make some small conclusions. And maybe later in the panel discussions, our experts can give us some important or very educational comments. First, introductions. Atrial fibrillation is the most common arrhythmia we all know. And why we concern? Because early identification of the atrial fibrillations may lead to the early treatments of atrial fibrillation, and later we can prevent atrial fibrillation-related stroke and other comorbidities. As we know, atrial fibrillation is very popular, and it affects more than 40 million people around the world. And the incidence rate is increasing year by year. Also, besides, the atrial fibrillations in these tables, the hospitalization rates about 10 years ago, overweight, heart failure, and the myocardial infarctions. It indicates the atrial fibrillation prevents incidence, and also the comorbidity management is very important. And to be back, if we can early detect or even early predict the atrial fibrillation, maybe we can do some works to prevent it happens. So till now, how can we detect the atrial fibrillations? Maybe we can use the menu palpations, or we can using for this possible or symptomatic patients like the symptom of palpitations, we can using the complete EKG to make a diagnosis of atrial fibrillations. If the ECG cannot confirm our suspicions, we can extend the monitor period, like using the 24 hours ambulatory ECG, event recorder, or even the root recorder to detect the possible atrial fibrillation presentation. And as we know, the wearable device is well prevalent. So from the Apple Heart study or using the Huawei watch, the MAVA2 studies, all published 4 years ago in the NEJM and the JACC. It says for these possible patients or symptomatic patients, the possible arrhythmia later further confirmed is the atrial fibrillations. The positive preview rate from this wearable device can up to 0.84 or even 0.92 for those high risk or symptomatic patients. So till now, how can we detect or how can we diagnose atrial fibrillations? We need the evidence. The evidence is the service ECG or the Holter or the loop recorder, or even by the suspicions of the wearable devices. So let me think about the AI. How can AI play a role in the predict the atrial fibrillations? There is a movie clip from the movie.
Look at me. Positive for Howard Marks. I'm placing you under arrest for the future murder of Sarah Marks and Donald Dubin that was take place today, April 22nd, at 0800 hours and 4 minutes. No.
So from these movies acted by the Tom Cruise, the Minority Report, is play a cop in the futures. The cop can using a single device to detect or predict the future criminal events, and before the criminal commit is weird, the cop can arrest the criminal. So the disease maybe fibrillations can be controlled before the event is even convened. Like this topic want to do, like this patient is only document with a normal sinus rhythm ECG, but can we use the normal sinus ECGs to detect or predict the future event of the atrial fibrillations? I think this is maybe the more important part of this today's topic. So let me brief introduce to the AI. The AI is a technique to enable machine to mimic human behavior. Under the AI substantials, there is a subset called machine learning. The machine learning is the subset of the AI technique, which uses static method to enable machine to improve their experience. And also the subset of the machine learning or the AI is the deep learning. Deep learning is like the making the computation using the multi-layer neural network, like our brain network doing this. So let me use this figure to describe. The top is the machine learning models. Maybe we can put an image like the dog image, and we choose more important features like the dog have 1 mouth, 2 eggs, 4 legs, 1 tail, something. And these features, we label these important features. Then we using the machine to do the classifications. And after the machine classification or computations, we will have some scores and to differentiate this image is dog or not dog. So how about deep learning? Deep learning is combine the feature extraction and the classifications. Because from the machine learning, human or we give the computer the specific features, we think the most important features. But in the deep learning models, the computer or the machine will extract the features doing by themselves. They will decide which features is more important than others and putting it more higher weight to calculating the results. Then we will know, okay, the input is dog or not dog. So how about the challenge in the AF predictions? So we think the atrial arrhythmia is come from some structural changes before the atrial arrhythmia developed. So previous studies almost work on the P wave or the PI interval changes compared with the atrial fibrillation patient and the others to detect which this normal size reason ECGs, which one will these patients will develop atrial fibrillation later, which one will not develop atrial fibrillation later. So before our topic today, previous risk scores like the Framingham Average Charge AF or the Japanese simple risk score like the Taiwan AF scores, we choosing some clinical or ECG factors and using the factors to choose scores. And after the scores, we differentiate the higher risk to developing maybe 5-year, 7-year, or 10-year risk of high risk of atrial fibrillation patients. All these models can only achieve 0.75 to 0.78 accuracies. And only the Freeman score and the Charge AF scores incorporate some ECG factors like the PI interval or the LVH, etc. So let me introduce recent studies about AI in the normal size reason to predict the future atrial fibrillations. Before we start, we using these simple illustrations to describe about the deep learning models. First, the input layer is we input the images into the computation process. Then we using the CNN model or other models to process these images, and they will decide which feature is more important, and using these features to calculate the output, the results. And the result will be normal or abnormal. But besides we using the CNN, this process layers, maybe we can using the flattening layers. This flattening layer like the clinical risk factor, like we can also put into the age, sex, and the other disease conditions, comorbidities into calculations. We think more information may be making our prediction more accuracy. So this is a very simple illustrations about the deep learning models. So from this Mayo Clinic's very well-known studies is published 4 years ago in the Lancet. It's using the CNN model as their deep learning models. And they incorporate 180,000 patients and using more than 650 normal size ECGs, and it can achieve the prediction power of AUC more than 8.7. And under the using more data, the extending data improvements, the AUC even can reach up to the 0.90s. And in these studies, it point out that illustrate that using the AI enables normal size ECGs, maybe we can predict the future atrial fibrillation events. And using these deep learning models, the choosing which images or which data we use is very important. So let me use this figures to describe. For upper is the patients grouped into the no atrial fibrillation groups. They during the medical records or all available ECG data, no atrial arrhythmia, no atrial fibrillation, no atrial flutter detected. So the index ECG is the first time ever known ECG available. And until all the follow-up periods, all the ECGs will incorporate into the window of the interest. And the more important is for those atrial fibrillation group patients. The index ECG is the first ever known ever diagnosis atrial fibrillation, atrial flutter ECGs. Because our hypothesis is atrial fibrillation is developed due to the atrial arrhythmia or the cardiomyopathy, something. So we think the development of the cardiomyopathy or the ECG changes maybe only precede the index ECG atrial fibrillation diagnosis before within 1 month. So the time of the interest or window of the interest is the ever index document atrial fibrillation ECGs before within 1 month, and later during all the follow-up period, all the data will incorporate into the analysis. So the blue line is the using only the primary analysis is using only the first one ever known normal size ECGs within the index window of interest, like the index ECG within 1 month, the ever first ECGs. And the red line is the incorporates not only the first one, but only the second and the third ECG before the atrial fibrillation diagnosis, all incorporated into calculations. As we know, more data and the more ECGs, we can get the better accuracy. So we can making the prediction power from the 0.87 to the 0.90s. And the second studies is published in the circulations and from the group in the Pennsylvania. It's using more even bigger database. It's using 1.6 million ECG tracings from the 430,000 patients. And using the deep learning model to training, it also can also yield 0.85 AUCs. And it's very good results. And this study, very interesting, is also trying using the ECG, normal size ECG, to predict the future's atrial fibrillation related strokes. It also can give the prediction power more than 62%. And this is another interesting of these studies. It compares 3 different models. The gray one is only using the age and the 6, no ECGs, to put into the deep learning models and to see whether age and 6 can predict the future atrial fibrillation events. And the orange line is using only the ECG tracings, and the blue line is using the ECG tracing and also clinical information, age and the 6. We can know for all the people or the labels normal or abnormal ECG peoples, more information we get, more higher accuracy we can get. So the ECG tracings, we can get the accuracy about 0.83. But if after we incorporate ECG, age, and 6, we can achieve 0.84 accuracy. So this study is also using the DNA trained models and compare with the previous, as we know, the traditional predict atrial fibrillation events risk score, like the Charge AF, ERIC, or Freeman Heart studies. All these traditional risk scores can only achieve the accuracy about 0.77. But in the DNA trained models, we can get the accuracy up to 0.85. So this is the recent 2 years using the CNN model or deep learning model to predict the future AF. How about the machine learning? This is the study from the Japanese, and it incorporates only the 13 1,000 sinus rhythm ECGs and using the machine learning model, random forest algorithms, and using these parameters, they think all the maybe the Q wave, T wave, R wave, QRS, all the segments of the ECG, of the segment of the ECGs can predict or can contribute the future's atrial fibrillation prediction powers. So these machine learning models can achieve the prediction accuracy up to 0.999. So in summary, I cite I using these 4 years the 3 very important models using the AI using the AI and the normal size ECG to predict the future's atrial fibrillations. The CNN and Tien model can get the accuracy more than 0.85. And if you're using the machine learning model, maybe we can get the more better accuracies. So, ladies and gentlemen, I tell you that maybe the futures can be seen. The fibrillation maybe can controlled before the event is ever committed using the AI models. But the basic hypothesis is that we think the atrial fibrillations develop, there is some structure, the myocardium or the cardiac structure changes before the atrial fibrillation attack detected or developed. So we using the ECG features like the PR interval P or the ST QRS somehow. The difference between the normal size group and the atrial fibrillations, there may be some difference. And we try to detect the tiny difference to see whether we can detect the future atrial fibrillation events. But for these studies, the key limitation is the currently, as we know, the deep learning models, because the machine itself to pick up which features is more important, not like the machine learning models. We give the machines, okay, which features is more important. So the AI studies or the CNN, DNA related neural network studies is lacking the explainabilities because we cannot know which features is more important, because the feature importance, maybe this is a trait or this is a hint tell us, okay, maybe for some changes is more important to leading the atrial fibrillations develop, or patient will suffer from the atrial fibrillation more. And this is also the limitations. For these studies, we need a very, very large cohort. We need a large database to do the training validations. And also, we need to refine the data because maybe we still don't know the race can also play any difference in these ECGs or the AF prediction or developments. And besides, as the study in the circulations, can we also combine not only using the normal size ECGs, if we combine more informations like the age, gender, or other clinical features or biomarkers, can more advanced or refine our AI models to predict the future atrial fibrillations. And more important is computer. If we want to use computers to involve in our patient management, it's very important, but it's also very dangerous. So these all models should be supervised by the human beings. And the future study or the further studies, maybe in the AI models, not only in the predict the future atrial fibrillations, maybe we can put back, we can using the AI model, using the normal size ECG to pick up more higher risk patients. Maybe they have a high risk to develop future atrial fibrillations. And these patients, like the previous speaker says, maybe for these higher risk patients, maybe for the stroke preventions, maybe we can consider using the anticoagulant, not the antiplatelets. And also, if for these high risk patients, although now we cannot make the diagnosis of atrial fibrillations, but maybe we can encourage these patients or these people to undergo the long-term cardiac monitoring, like the Holter event recorder, loop recorder, or even the Apple Watch to monitor the possible atrial fibrillation events. And also, for these patients, as we know, the atrial fibrillation measurement is we endorse the APSC pathways. So for these patients, maybe the comorbidity control, maybe for these patients, we can do more about the comorbidity controls. So ladies and gentlemen, let me make the conclusion of today's topics. I think the atrial fibrillation is frequently asymptomatic. We need the prolonged cardiac monitoring to making the sure or the final diagnosis of the atrial arrhythmia or atrial fibrillations. Sometimes this is low yield and very costly. And besides, these patients need more intensive monitoring and measurements, even not the disease itself, but also the comorbidity and the mobility, mortality monitoring and the controls. So using the AI models, maybe can provide these questions some solutions, like we can get these patients better patient solutions for the long-term monitoring using the AI or other devices. And also using these models, maybe we can design some clinical trials to start anticoagulations for those very, very high risk for the future atrial fibrillation victims. This is today's my topic, and thank you for your attention.
Thank you, Dr. Huang, for your excellent presentation of reviewing AI in prediction of future atrial fibrillation. Any question or comment? So, Dr. Huang, you mentioned that, of course, if we incorporate more data into the AI model, it could be more accurate. But
Yeah.
Do you think about if you use more data, and then the model actually is somewhat hard to apply, because you need, when you want to use the model, you need to collect a lot of the data.
Yeah, thank you, Professor Chang. Like we try to find the criminals, more information we get, we can have a higher probability or higher confidence for the criminal convenience. So in these circulations models, so they only using the age, sex, and the ECGs. Maybe we can choose more important but easy to get informations, and to incorporate these factors into calculations or into considerations. I think more informations we can make in higher confidence, but which factors should be put into the models? We should balance the accessibility and also the predict powers. Yeah, I think this is very important.
Thank you. Okay, thank you, Dr. Huang. If there is no more question, let's move to the final presentation by Dr. Balbir Singh from India. Dr. Singh is now chairman and the head of cardiology at Pan Max Hospital in India. The title of his presentation today is that atrial appendage occluder in prevention of thromboembolic stroke in chronic atrial fibrillation resistant or liable to OAC, target candidates and the long-term efficacy. Dr. Singh, please.
Yeah, thank you very much. Can I share my?
Sure.
Yeah, can you hear me now?
Sure.
So I'll share my screen and I will present my slides. Not able to share. Can you see my slides?
Not yet.
Not yet. Okay, let me try to share again. Not able to connect. Don't know how to do it. I'm pressing share screen and then basic
Did you select
whiteboard.
the screen you like to share?
Yeah, I selected. It's not coming. Now I'm the screen that I want to share. Can
Then-
you see it?
Oh, it's coming.
Okay, thank you. So let's look at LA device closure for atrial fibrillation in stroke prevention. Where are we now? That is the major question, that have we reached a stage where we can say this therapy is there for many patients? So if we go back to the year 1969, that is the time of interest in atrial thrombosis and systemic embolism actually came. And this was a autopsy material where patients who had a systemic embolism or a stroke were studied, and the left atriums were examined. And it was seen that many patients with atrial fibrillation had clots in the left atrium, which was probably responsible for the embolism. So that was the first chapter in the history of stroke and atrial fibrillation was actually written. Several years later, when transesophageal echo came into being, it was clear that left atrial thrombus was a very important factor in patients with acute and chronic fibrillation. And many patients with a recent embolic event had a left atrial appendage thrombus. So the conclusion at that stage was that left atrial appendage, which has very low blood flow in atrial fibrillation, is the main reason for clot formation and embolism. So from 69, we went on to 1995, when TE was first introduced, to understand actually that the left atrium is a very important structure in atrial fibrillation. You can see many studies put together. 91% of all thrombi are in the left atrial appendage in patients who have atrial fibrillation. But this is true for non-valvular atrial fibrillation. For valvular rheumatic, even the body contributes a lot to thrombosis. So in non-valvular atrial fibrillation, you can see multiple studies put together show that left atrium has a very low chance of having a clot. It is the appendage which majority of the times, 91% of the times, will have a clot. So that is the main area of focus, because we now understand majority of clots in non-valvular atrial fibrillation embolize from the left atrial appendage. But we can't forget that rheumatic and other etiologies may have a thrombus in the left atrium itself. If we went from 95 multiple studies showing the benefit of oral anticoagulation, initially warfarin, and now the NOACs, has been the therapeutic mainstay for stroke prophylaxis in atrial fibrillation. So undoubtedly, this therapy is there to stay, has shown outstanding benefits in patients with atrial fibrillation. And NOACs have now become the treatment of choice because of their safety profile, because of their food to drug interaction, and also the lack of doing INR. So they have become the mainstay of treatment for patients with stroke prevention. However, anticoagulation may not always be possible because of personal history of bleeding, the risk of bleeding, particularly with elderly and frail people who may fall or who have cerebral amyloid angiopathy or have severe hypertension. The risk of these people having a bleed is very high. Particularly, guidelines are quiet on people who are 85 age and above. What should be the best anticoagulation therapy. Most of the trials had excluded this age group of patients. So anticoagulation may not be possible in all patients because of history of bleeding, history of risk of bleeding, high risk occupations, or documented non-compliance. Some people do not want to take oral anticoagulants. As a result, anticoagulants are not utilized or not maintained in 50% of the cases. So 50% of the cases will end up having no anticoagulation whatsoever. So the concept was that the appendage is the main area for source for thrombus formation. This led to development of LA appendage closure devices, which led to some pivotal trials. And these pivotal trials had positive results. And this led to many centers adapting this form of therapy of LA appendage closure. As a result, you can see the rising numbers in America of LA appendage closure devices. The first device was the Plato, and this led to international multi-center feasibility trials. So this was the first device which was used to close the appendage. And the good thing about was the success with which it could be implanted, with success rates of 97.3%. So it was first time thought that this is feasible, can be performed at an acceptable risk, and is a good alternative in patients who have contraindication for anticoagulation. So this was a study published in 2005. This led to 3 randomized trials. So without randomized trial, we just cannot defy a therapy which could have potential complications and could also lead to systemic embolism later on. So we had to have some randomized trial, and we have now 3 large randomized trials. You can see the PROTECT-AF, PREVAIL, and the PROC-17. So PROTECT-AF was in about 700 patients, 460 in the device arm, 244 in the control arm. PREVAIL had 269 in the device arm and 139. PROC had a device which could be an Amplatz device or a Watchman device, and a control group with 201 patients on anticoagulation. So in these 2 trials, it was the Watchman which was used, and you could see the primary safety endpoints were met. This embolism and the stroke risk was similar, so it proved non-inferior. So we went on to have a meta-analysis of PROTECT and PREVAIL. And if you see this, you would see the efficacy almost similar. But the most important thing is the hemorrhagic strokes were reduced remarkably by having a Watchman device. But it was in comparison to warfarin. So what if it was a NOAC instead of warfarin? Would the hemorrhagic stroke would have been this spot may have been on the on 1? Could it be possible? But if you see systemic embolism or ischemic strokes were a little higher in the group. And this major reason was the first 7 days procedure-related complication will lead to this problem. And now we're getting more experience with this device use. This has come down. All-cause death, you can see favor of a Watchman. Major bleeds, almost same. And major bleeds post-procedure. That means if you take out first 7 days, post-procedure, the events were less. So as we grow in experience, the major bleeds related to procedure or ischemic strokes related to procedure have come down significantly, resulting in this data being skewed now. However, if you look at the guidelines, the last we had was 2020 of on use of LA appendage closure devices, still continue to call it 2B. Probably they want to wait for some more trials. But in addition, they write that if there are contraindications such as intracranial bleed without a reversible cause or very life-threatening bleeds, one should resort to LA appendage closure. Now we have so many trials which are going on, which is with large number of patients. And this would actually be very important for us, for guidelines to understand what's going on. And you can see a large number of trial size, 3,000 patients, 2,600 patients. This is comparing LA appendage closure with Watchman FLX, which is the new device from Watchman, compared against DOAC. So most of the trials are comparing against DOAC. You comparing Amulet versus DOAC, any of the device versus DOAC. So BK or versus DOAC here. And so you can see stroke close in patients who have intracranial hemorrhage, LA appendage with Amulet device versus medical therapy, which does not include an oral anticoagulant. So intracranial hemorrhage is clearly one indication. And these two trials are going to address this. Then is the compare LA appendage. So flex or Amulet versus antiplatelets or no therapy in patients who have a contraindication to NOAC. So the question was that patients have a contraindication. Still, they may not have that high risk. So this was the question, and this is going to address that. So you can see a lot of things happening in the near future, and over the next 2 to 5 years, we'll get results from many of these trials, and that is going to be the basis of what guidelines could change in favor of an appendage closure. Appendage closure has some issues. One is a device-related thrombus. So there are published reports of device-related thrombus, and there are clinical characteristics, procedural factors, post-procedure treatment, whether it's OAC or 3 months of anticoagulation, all that are there. But this is rare complication. This is seen in 3.5% of the patient. But the issue is that if somebody has a device-related thrombus, there is a chance of embolization, and they may need a short-term anticoagulation. The dose may be less. Then there is a peri-device leak. For example, this is a Watchman device placed here. There is edge is not coaxial and not closing this part of the appendage, and there could be leak. So this is a procedural effect which can be actually corrected. Or there could be a lobe of the appendage which may not be in contact with the Watchman device. So one has to be careful in picking up bigger size if there is a lobe here. Similarly, there could be a lobe which is not at all in the appendage. It's coming separately from the LA, and this could be another issue. But these are all procedural issues which can be sorted out. So, but the problem is that we should be aware of this. If we leave a peri-device leak, they have a higher incidence of stroke or systemic embolism. That means we have been learning. Over the last few years, we have been learning how to place these devices, how to get the best results. And this is one of the reasons that this device is now being used more often, because it has become much safer. We've understood how to deploy it. Now, 3D computer modeling of CT scan images can also help choose the devices, look at different lobes, decide where exactly you have to place, and may also be another beneficial effect. Like we do TAVI, we do a 3D CT. So LA appendage closure may need a CT with a 3D modeling to actually understand what size of device we may use. So there are large registries. This is a registry of 40,000 patients from the, which is the Lao registry group, which clearly shows procedure success, which is very high, 99.3%, compared to many of the trials. So evolution and Lao registry have similar. The major complications were mainly pericardial infusion, which required synthesis in 1.3% of the patient, which still continues to bother us. Then others are very small incidences. So if you look at in this registry, when was a device chosen? The chosen device was when there was increased embolic risk of stroke. That means the CHA2DS2-VASc score was very high, and the patient had a TI or a minor stroke despite oral anticoagulation. This was one indication. History of major bleed was another indication why LA appendage closure device was chosen. High fall risk, particularly in the very elderly, and anticoagulant can be very difficult to choose, was another incident. So you can see 2016, 17, 18 practically remain the same. Labile INR is less of an issue with NOACs available. Patient preference, one third of the patients actually prefer to get a LA appendage closure when they were discussed with as compared to oral anticoagulation. And non-compliance with anticoagulation was one indication. So you can see the indications of in this registry with 38,000 patients, how the physicians felt and how the patients felt about the need of this device. And thank you very much for your kind attention. I can answer any questions if they're possible.
Okay, thank you very much, Professor Singh. Any question? Oh, okay. Dr. Singh, what do you think if patient also need catheter ablation for atrial fibrillation and also need for LAAO? Do you prefer performing the procedure in a one-step procedure or sequentially?
Okay, if it is the first ablation, I would like to avoid it because of the simple reason that he may need a second procedure, and an appendage closure device, particularly an Amplatz device, covers that hole and also covers the area, the ridge between the LA appendage and the pulmonary vein. So it may make the second ablation more difficult. But if it is a recurrent procedure, or if the chances are that he will not stay in atrial fibrillation despite multiple lines, I would think a combined procedure is better.
Okay. And what is your current strategy in this patient after LAAO? What is your anti-thrombotic strategy after implanting the occluder?
So anticoagulate strategy, if we are using an Amplatz or an Amulet device, a single antiplatelet is enough. But if you're using a Watchman device, the guidelines say warfarin, but we have started using NOAC in lower doses. Suppose it is dabigatran, we give 110 milligram twice a day. The problems come patients who have intracranial hemorrhage. When the neurosurgeons don't allow us to use anticoagulants or antiplatelets, that is the major issue, and they need a device because they are in permanent atrial fibrillation. Now they had a hemorrhagic stroke. So we wait for some time and generally give a device after 15 days. And most neurosurgeons allow us to use at least one antiplatelet after 15 days of intracranial bleed.
Okay. Dr. Yuo, do you have any question or comment?
Yeah, Dr. Singh, just want to check. So there are actually some questions now being asked, with especially with Watchman Flex being a much easier, lower learning curve procedure, and some of them are actually thinking of offering even in patients who are not high risk for anticoagulation. What do you think about it?
So I would think that as an interventionist, I love this procedure, but the guidelines don't want more randomized trials. And one of the problems with the Watchman device was the pericardial effusions, even on the late term. That easy implants and lower incidence of pericardial effusion. But as I said, there are multiple trials going on, and we need to get the randomized data. The PROTECT and PREVAIL were very old trials and compared it against warfarin. So I think we need some more data before we actually embark into low-risk patients.
Thank you.
Okay. So if there are no more questions at the end, I want to thank Professor Junli Lin for organizing this APSC Club Forum focused on discussing atrial fibrillation therapy. And we also like to thank all the faculties from Singapore, Vietnam, Japan, India, and Taiwan. So I conclude this section. Thank you very much. Thank you, everyone.
Thank you.
Thank you.
Dr. Junli Lin, do you have
Yeah.
some words?
No,
Okay.
I will thank you all for your contribution to the success of the section. Thank you all. Thank you very much.
Thank
We will
you.
see you all in the future. Okay,
See
see you.
you.
Okay,
Thank you.
bye-bye.
See you.
Yeah.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.